Dear colleagues, the Institute for Clinical and Experimental Medicine in Prague is one of the leading centers in Czech Republic and in Europe. We are also one of the centers with great experience with Farapulse pulse field technology for ablation of atrial fibrillation. And we learned in our experience that intracardiac echocardiography is particularly useful for guidance of the procedure and for proper alignment of the catheter with the tissue. We prepared this video for you to share our experience. So, welcome to our EP Labs.
Hello, my name is Peter Peikel. It's my pleasure to guide you throughout this video. First, let me introduce the patient. It is a 65-year-old male with arterial hypertension. He has a history of atrial fibrillation for about 1 year. He underwent 2 electrical cardioversions despite use of propafenone. On echo, he has a normal ejection fraction, and his left atrial volume index is 36. The shown procedure is performed in general anesthesia, but alternatively, deep sedation using propofol can be also effectively used. We currently perform about half of our cases using deep sedation and propofol. It's our standard protocol to obtain 3 venous accesses for transeptal sheath, ice, and coronary catheter. We administer heparin after securing vascular accesses, and we target ACT level to 300 to 350 seconds. We also administer 1 mg of atropine at the beginning of the procedure to prevent vagal reactions during applications of pulsed field energy. For the purpose of this video, we have divided the procedure into separate parts. After induction of general anesthesia, vascular accesses are obtained by ultrasound guidance. In general, ultrasound guidance is recommended, especially as large-bore cannulas like Faradrive sheaths are being deployed. Linear probe with sterile cover is used. Artery and vein can be easily differentiated as vein is fully compressible. Once vein is punctured, a long wire for transeptal sheath can be inserted. Femoral veins in the left groin are cannulated in similar fashion. These are used for intracardiac echo and CS catheter. During puncture, small tethering movements with the needle may help to visualize the needle location and direction. 7 French and 11 French sheaths are inserted over the wires. Once in place, all are flushed with saline. For the purpose of this video, we have prepared a short tutorial of intracardiac echo. We use phased array Akusan Akunav ultrasound catheter. After its unpacking, the catheter is covered by sterile draping and connected to the ultrasound machine. We use ice image during guiding the ice catheter through the pelvic veins. Alternatively, a long 11 French sheath can be inserted into the femoral vein to facilitate passing through the pelvis. When ice catheter is inserted in the heart, it shows the right atrium. There, tricuspid valve can be usually easily identified, and this view is called the home view. In the home view, right ventricle, RVOT, and aorta can be differentiated. Then, the ice catheter is slightly inserted into the right atrium and rotated clockwise. There, left atrium and interarterial septum with fossa ovalis can be seen, together with mitral valve and left atrial appendage. Then, the ice catheter is rotated more clockwise, and left pulmonary veins can be seen. Further clockwise rotation will show esophagus behind the left atrial posterior wall and then right inferior pulmonary vein. If clockwise rotation is continued, right superior pulmonary vein and the right pulmonary artery can be seen. To get back to the home view, the catheter should be retracted and rotated counterclockwise. To get the other view of left atrium, the ICE catheter should be inserted into the right ventricle. This is done from the home view by anteriorly bending the ICE catheter and then passing through the tricuspid valve. The RV apex can be seen, and if the ICE catheter is rotated clockwise, left ventricle will be visualized. Further clockwise rotation will show aortic root in short axis, and behind aorta there is a left atrium. This is an important view as it enables visualization of the ridge between the left-sided veins and the left atrial appendage. Proper positioning of the ablation catheter with respect to the ridge is important for successful ablation. Transeptal puncture is done under ICE guidance using the broken brow needle. First, the long wire is inserted into the superior vena cava and then transeptal sheath is inserted along the wire. For transeptal, we use SL1 sheaths. The broken brow needle curvature may be enlarged according to the individual patient anatomy. The needle is then inserted into the dilator, and distance of about 2 fingers width is maintained between the hub of the needle and the sheath. The hub of the needle should point into the direction of 4 to 5 o'clock position. Then the whole assembly is put back under fluoroscopy into fossa ovalis. The correct position of the tip of the sheath is confirmed on ICE. Then the transeptal needle is fully inserted into the sheath and the whole assembly can be carefully pushed to facilitate the access. Small amount of saline can be used to confirm that the septum has been successfully punctured. Then the needle is pulled back and the sheath is carefully inserted into the left atrium. Finally, the dilator with the needle is slowly removed to avoid air suction into the sheath. Wire is then reinserted through the sheath into the left atrium to guide insertion of far drive sheaths. Far drive sheath is used to manipulate the far wave ablation catheter in the left atrium. It comes packed with the dilator. Prior insertion into the body, both sheath and dilator should be flushed with saline. Steering mechanism may be tested prior dilator insertion. Moistening the dilator will facilitate its insertion into the sheath. Then, the Farawave ablation catheter is unpacked and prepared. Availability of long tray table is of advantage for flushing the catheter. A stiff wire with J-shaped tip is used for anchoring catheter inside PVs. The Farawave is first flushed with saline and then the stiff wire is inserted. With the wire inside, different configuration of the catheter tip may be tested, the basket and the flower. The proximal portion of the catheter is also flushed with saline. Then the steerable sheath is inserted to the left atrium. First, the SL1 sheath is removed and exchanged to Faradrive sheath. The sheath should be gently rotated when passing the skin in the groin. During introduction, the end of the wire should be positioned inside the left-sided veins, not in the left atrial appendage. Gentle push and manipulation is required to pass the septum into left atrium. It is important to remove any air bubbles inside the sheath and flush it properly. Then Farawave catheter is connected to flushing tube and the Farawave catheter is inserted into the Faradrive sheath. This should be done slowly, and again, any air bubbles inside the sheath should be removed. This is done by aspiration of blood and flushing with saline. Then the catheter can be inserted into left atrium. Importantly, during the catheter insertion, the anchoric wire should be positioned in the left-sided veins and not in the appendage. Once inside left atrium, the Farawave catheter can be put in basket configuration. Correct position of the catheter inside the PV should be adjusted based on ICE image. This might be too distal position as the equator of the basket is too distal. This is the corresponding fluoroscopic image. This might be too proximal position. This is the corresponding fluoroscopic image. And finally, this position seems to be optimal as it nicely covers the ridge. X-ray image shows that it may be difficult to assess the position of basket with respect to the PV. These are the signals in the PV antrum prior to the application of pulse field energy. The pulse is 2.7 seconds long, and even after just one ablation, all PV potentials will disappear. Additional application is delivered with the same position. Then the Farawave catheter is rotated about 30 degrees and the third and the fourth applications are delivered. During applications, the intracardiac electrograms are distorted by artifacts. Then the catheter is changed into the flower configuration. Fluoroscopy and ICE are used to optimize positioning. This is to anterior position as it overlies also the left atrial appendage. With clockwise rotation of the sheath, the position can be adjusted. Then applications 5 and 6 are delivered. Subsequently, the Farawave is rotated about 30 degrees and position is checked on ICE. Applications 7 and 8 are delivered. As ablation of posterior wall is planned in this case, additional applications are delivered more towards the posterior wall. The wire is still retained in the vein. These are called anchoring lesions. Before moving into the left inferior pulmonary vein, the Farawave catheter is straightened and the wire is withdrawn from the left superior PV. Then the wire is manipulated carefully into left inferior PV. Again, the position is optimized based on ICE image and fluoroscopy. 2 applications are delivered with basket configuration. Then the catheter is rotated about 30 degrees and checked on ice. 2 applications are delivered with this position. Then the configuration is changed to flower and ice is used to optimize positioning. Fluoroscopy is used to check proper separation of the petals. 2 applications are delivered in the flower configuration. Then the catheter is rotated and checked on ice. Applications 7 and 8 are delivered. Finally, additional 2 anchoring lesions are delivered towards the posterior wall with the wire retained inside PV. Before moving towards the right inferior PV, the catheter is kept in the flower configuration and the sheath is rotated clockwise. This allows to position the catheter on the antrum of right inferior PV. Then, the wire is inserted into the PV. The position in the antrum is optimized under ice guidance. Once optimal position is reached, first application is delivered. During the application, the catheter may be dislodged into the vein and repositioning may be necessary. Now the catheter is retracted and repositioned. Then the application should be repeated and subsequently second application may be delivered. Then the catheter is rotated and additional 2 applications are deployed. If posterior wall ablation is planned, additional anchoring lesions should be delivered towards posterior wall. Then the catheter is moved into basket configuration and position is optimized under ice guidance. 2 additional applications are delivered. And then the catheter is rotated and last 2 applications are deployed. To move the catheter from the right inferior to right superior PV, the catheter should be retracted and the sheath straightened and rotated clockwise. Then the right superior PV is cannulated with wire. Basket configuration is created and position is optimized on ice and fluoroscopy. Then the first 2 applications are delivered. Subsequently, the catheter is rotated 30 degrees and position is checked on ice. Third and fourth applications are delivered. Then the catheter is changed into flower configuration and the position is optimized based on fluoroscopy and ice. 2 applications are again delivered. Catheter is rotated about 30 degrees and position is checked on ice. Additional 2 applications are delivered. It is our practice to deliver additional safety applications to the anterior aspect of the right superior PV. This is achieved by clockwise rotation of the sheath. 2 bonus applications are delivered. As the posterior wall ablation is planned, 2 anchoring applications are delivered towards the posterior wall with the wire retained in the vein. For posterior wall ablation, the catheter is in flower configuration and wire is retracted to its tip. The navigation is done by the sheath and the series of applications are delivered sequentially on the posterior wall. The first application is done close to the right superior PV and then the catheter is moved towards the left-sided veins. Contact is confirmed by ice. We believe that this might be crucial because after few pulsed field energy deliveries, there are usually no detectable electrograms to verify good contact with the tissue. We aim to have about 50% overlap of each position with the previous one. At each side, 2 applications are delivered. After left-sided PVs are reached, the sheath is slightly bended towards inferior aspect of the posterior wall. The applications are continued in similar fashion. The catheter is moved from left-sided veins towards right-sided by clockwise rotation of the sheath. These applications are delivered on the top of esophagus. However, as pulse field is used, no clinically relevant esophageal injuries were reported so far. Again, we aim to have about 50% overlap between positions. The ice is used to confirm good apposition of the flower against posterior wall. At each side, 2 applications are deployed. After completion of the ablation, all pulmonary veins are checked for presence of PV potentials and exit block. This is left inferior PV, note absence of electrograms and exit block during pacing. Then the catheter is moved to the left superior PV. No PV potentials are present and pacing within the vein is not conducted to atria. This is cannulation of right inferior PV. Note the presence of dissociated activity within the vein. Then the catheter is moved towards right superior PV and isolation of the vein if exit blocks are checked. Finally, the catheter in flower position is steered towards posterior wall and absence of electrograms and exit block are confirmed. Then all catheters are retracted. The cannulation site is closed by a figure of 8 suture to achieve venous hemostasis. After tightening of the suture, no bleeding is observed despite full anticoagulation with heparin. This is the procedure summary. We have performed PV isolation and ablation of posterior wall. There were 8 applications per vein, plus 2 bonus lesions. For posterior wall, we have delivered 20 applications of pulse field energy. Total procedure time was about 1 hour. So this is it. I hope that you enjoyed this video and learn how to use eyes to support your Farapulse cases. We wish you a lot of successful cases with this new disruptive technology.